and good evening, everyone. Lydia's managing the admissions, which is very, very grateful for that. It's my great pleasure to introduce Professor Ali Khurram from University of Sheffield, just the other side of the Pennines from me at the moment. Professor Khurram was trained in dentistry and then went into medicine and pathology. He did a PhD at the University in Sheffield in head and neck cancer, looking at cytokines, and he's professor of oral and maxillofacial pathology in Sheffield. He's also the founder of the Neopath Research Group, looking at head and neck diagnosis and prognosis prediction. Great pleasure to have him here today. Odontogenic tumours, relatively uncommon, probably not that rare, and difficult because of their uncommon nature. It's an important topic. I must say I've never met Professor Khurram, but it seems that we've met a very great number of people kind of in common. So I feel I've virtually met him. So thank you very much, everyone, for your attention and interest. And without further ado, I'll pass over to Professor Khurram. Thank you very much.
Thanks a lot, Richard, for the kind introduction and for asking me to speak. And thank you to all of you who are joining.
Sorry, Lydia, are you recording this?
Yep, I have it recorded.
Okay, I'm just trying to see how I can record it as well. Okay, over back to you.
So I'll just be giving you an overview of odontogenic tumors today. So there's quite a lot of them, and I unfortunately can't go into each one of those, but I'll try to talk about some of the changes in terminology and some of the additions to the WHO classification over the recent years as well, and try and give some examples with some of my cases too. So yeah, I'll just start with an introduction, talk a little bit about WHO classification and the diagnostic challenges, and then also talk throughout the talk about the importance of radiological correlation. So a fair bit has changed over the years, but the number of tumors has been more or less similar. So going back to 1971, we had 30 odontogenic tumors, and you can see in 2017 there was actually a fewer number because there was an attempt to simplify the classification. In the most recent 5th edition of WHO head and neck tumor classification, there are no major or wholesale changes. The big change is that the categories, they've been slightly rearranged. So these are the main themes in which the lesions are distributed. But in terms of addition of new things, you've got the addition of adenoid ameloblastoma, which is now a recognized separate type of tumor, if you like. Rhabdomyosarcoma with the TFCP2 rearrangement, and the surgical ciliated cyst, which although has been a known entity for a while, but has now been added to the classification. So before I get into the pathology, I thought it'd be good to just briefly look at the radiology. So this is what we call an orthopantomogram or dental panoramic radiograph. So here's the mandible, the lower jaw, that's the maxilla. This line that you're seeing is the hard palate. So it's very important for us to actually see whether things are normal, what's the size of the lesion, the shape and the color, etc. Because a lot of the histological features can sometimes be overlapping and difficult. So we look at the border and whether it's well-defined or not well-defined. We look at the changes in the adjacent structures. So if there is any, sorry, there's some feedback coming from someone. If there's any resorption of adjacent teeth or any other structures. And then we also look at the locularity. So is the lesion present all together as a whole, or you've got multiple different compartments within it? So for example, a unilocular lesion will look just like this, whereas a multilocular lesion can have a variety of appearances, but you can see it's got these multiple sort of circles within or divisions within. So I'll start off by talking about primordial odontogenic tumor, and this was added to the last classification and first reported in 2014, still a very rare tumor, usually in younger patients, and 60% of the patients are male, and it presents as an asymptomatic swelling, usually on the buccal aspect, but it can be more extensive and can go across to the lingual and palatal aspect of the jaws as well. And if you look at the radiology, they are quite well-defined lesions. So it looks quite dark, which means it's radiolucent, but it's also got a very well-defined border as well. And almost all of these are associated with an impacted tooth or an unerupted tooth as well, which we call a dentigerous relationship. But it can cause root resorption. And here you can see this tooth, the root has been resorbed or has disappeared somewhat. If you look at the macro of this, so it looks like a multilobular sort of mass, pale in color. It's not cystic. And when we actually look at the histology, it's got quite loose fibrous tissue. It's got quite a sort of mesenchymal appearance with lots of stellate fibroblasts. And this is lined by epithelium, which is called this columnar appearance, quite characteristic of odontogenic epithelium, where you see this palisading or shifting away of the nuclei from the basement membrane. And this very much resembles the inner enamel epithelium. And this is a picture from developing tooth. And this is the epithelium, which will eventually form enamel. And it looks very much like that, a tooth in its sort of a developmental stage. And here's some examples of these. So you can just see again the epithelium on the top with that columnar appearance and this stroma or tissue which looks quite variably loose and myxoid, but it is fairly cellular, although the cells or the nuclei are quite bland in features. So moving on to sclerosing odontogenic carcinoma, another entity that was added in the last edition of WHO. It is a low-grade malignancy, but if untreated, it is locally aggressive. Now, a lot more than 11 cases have been reported, but there's still a lot of debate. Some people are still questioning whether this should be an entity on its own or are these something else because of the rarity of these lesions and the difficulties in diagnosis as well. They don't tend to metastasize, so they remain localized to the jaws, and they almost always present like this, these like almost saucer-shaped or oval radiolucency between the roots of the teeth, and that's quite a characteristic appearance. Here you can see another example between the roots of these teeth, and there is resorption of the root of this tooth as well, which tells you is something more than just a benign cyst. And histology is fairly non-specific. So you get this stroma, which is quite sclerotic and fibrotic, as the name suggests. And within that, you've got these largely bland islands of epithelium, but they've got a very infiltrative appearance. They can show mild pleomorphism, but you don't tend to see mitosis or necrosis. But the big feature which helps in diagnosis is that they almost always show perineural invasion. The other important thing to remember is you need radiological review to see the extent of the lesion and whether there is damage to any adjacent structures. And sometimes you can just see areas which look very much like they could be amyloid. But if you were to do congruent staining on this, it will be negative. So here's another higher power example of these odontogenic epithelial islands, quite scattered with an infiltrative appearance. And here's an example or multiple examples of perineural and intraneural invasion. So here is a nerve, and you can see these tumor islands which are sitting within nerves. And there's a cytokeratin staining, which is actually highlighting those tumor islands within the nerves. But it's important to think about other things before you get to the diagnosis, because almost is a diagnosis of exclusion, if you like. Think about a primary interosseous carcinoma or a metastatic carcinoma. Odontogenic fibromas can have a very similar looking stroma, which is fibrotic with plump fibroblasts, but the epithelium looks slightly different. It is quite inactive looking odontogenic epithelial islands, quite well formed, and they don't have that infiltrative appearance. You also tend to see some hard tissue formation or calcification, something that you don't tend to see in a sclerosing odontogenic carcinoma. And an odontogenic fibroma also would not show perineural invasion. And sometimes CEOT can show similar sort of features, particularly the amyloid in the background can look like sclerosis, but it'll be congruent positive. And it will also show those calcifications that you don't tend to see in a sclerosing odontogenic carcinoma. So what does a COT look like? What are the important things to know? Again, benign, but locally destructive, just like most odontogenic neoplasms. Ameloblastoma is another one of those. Mean age of 40 years in terms of patient involvement, and the majority of these involve the mandible. And within the mandible, the molar region is the most common. Almost half of these are associated with teeth that have not erupted, but some can present just in the soft tissues as well. So something to be mindful of. And the radiology is typically of a well-defined lesion, but it's mixed in appearance because it's dark in places, but you also have these speckled calcifications, which tells you that this lesion is calcifying. And histology can show a variety of appearances, but the important thing is this very epithelioid appearance. And you can also see the sort of nuclear and cellular atypia and the variation. You can also get cytoplasmic clearing. I spoke about the atypia here as well. You can see there's some variation in nuclear shape and size, but you don't tend to see mitosis. The other thing that's important to note is that you'll get hard tissue formation in the form of dentinoid and amyloid. So if you do the Congo red, it would be positive, but you can see here there's quite extensive dental hard tissue formation. Now, if you were to compare this to odontogenic fibroma, now on radiology, it looks, again, quite well defined, but it's not showing that many speckled calcifications in it, okay? You've got both central and peripheral variants. So central variants, of course, are intraosseous and peripheral variants are within the soft tissue. It is quite rare, and basically it's quite dense looking fibrous tissue, which has got inactive odontogenic epithelial islands. So when you get a central lesion within the maxilla, it tends to be more in the anterior aspect, whereas in the mandible, it tends to involve more the posterior aspect of the mandible. They're largely asymptomatic and almost always an incidental finding. And if you look here, this is the typical appearance. You can see quite fibrotic stroma, but in places it's also quite cellular. And at the center of those sort of cellular plump cells, you can see these quiet looking odontogenic epithelial islands, but there's no calcifications in this, but you can get calcifications sometimes. So here's an example case. This is from a 2-year-old girl who presented with a mass at the anterior mandible, and the CT scan shows this expansile lesion. And you can see there's a tooth that's unerupted as well. It's also causing some resorption of the adjacent structures. If you look at the histology of this, again, it's variably dense tissue, slightly loose hair, more sort of hyalinized in this area. But you've got these scattered odontogenic epithelial islands throughout this, and they don't seem to have the same infiltrative appearance, and they won't show the perineural invasion we previously spoke about. So we're talking about clearing, and you can get clearing in sclerosing odontogenic carcinoma and CEOT. So it's important to know about another entity, which is called clear cell odontogenic carcinoma. Slightly older patient group, and largely involves the mandible. And when it involves the mandible, you get them in the posterior aspect more. They are slow growing, but you can have them present with ulceration and loosening of the teeth. Here's an example of clear cell odontogenic carcinoma. It's well defined in areas, but towards the superior aspects, it's difficult to tell. It's extending between the roots of the teeth, although it's not causing a lot of resorption here. And on histology, what you get is these sheets and islands of epithelium, which can show quite striking clearing. So here's an example which is showing a lot of clearing, but in other cases, it can look quite epithelioid or almost epidermoid, if you like, squamous looking appearance with only focal clearing. So you don't always see the clearing throughout. There's nothing in terms of immunohistochemistry that's specific to this tumor. But the important thing that helps us in the diagnosis is that more than 80% cases have got an EWSR1 rearrangement. So you can ask for FISH or whichever molecular test you may have available, and that is diagnostic and quite useful. But of course, it is also important to remember not to do it on decalcified blocks because your tests won't work. So looking closer at the histology, you don't get calcifications. Here you can see there's some example of cytoplasmic clearing, but other areas it looks more like strands of epithelium, which have got a slightly more infiltrative appearance. We need to look at the radiology. We need to do a molecular test. And this one seems to have more of a metastatic and recurrence potential than sclerosing odontogenic carcinoma. We don't know enough about these to be sure about the prognosis, but most of these tumors are low grade, and particularly the margins are clear as well. But it's important to rule out any other lesions with clear cell change in your differential diagnosis. So for example, a sclerosing odontogenic carcinoma, which can occasionally show clearing, metastasis from a distant site. For example, this is a renal cell carcinoma, can fairly commonly come to the jaws, but also you can get salivary gland tumors like mucoepidermoid carcinoma, including an intraosseous variant of it. So it's important to be mindful of those. So briefly touch upon mesoblastoma, but not in a lot of detail because that's an entity everyone is quite familiar with. Again, benign but locally aggressive. As we know, mandible is the most common site and it can recur and can be quite difficult to remove. And here's an example of a resection and a cross-section of the lesion. This is the classical example of an ameloblastoma. You've got these sort of follicular type islands, which are showing again that peripheral palisading, which is characteristic of odontogenic epithelium. And the central areas, which are a bit more loose, they are more like stellate reticulum. And again, going back to the tooth development stage in terms of the loose tissue that's involved in the formation of the tooth. But sometimes you can get this cystic degeneration as well.
The biopsy came back as a
There's another histological variant of it, ameloblastoma, which is the plexiform variant. And in the plexiform variant, you tend to get cords and strands rather than cysts and islands. But there's no obvious prognostic implication. It's more of an academic interest. Other appearances or variants that you can see is the acanthomatous one, in which you can get quite prominent keratinization. You must be aware of the unicystic ameloblastoma, which unilocular on radiology, but also looks like a cyst and sometimes can be quite challenging to diagnose. So it's important to get that right. And you can get sort of luminal proliferations of tumor island, but sometimes you can also get tumor islands going within the wall. But most of these tend to be just confined to the epithelial lining. And sometimes you can also get a peripheral version of an ameloblastoma, which is just within the soft tissue or the connective tissue of the gingiva or the gums, and there's no intraosseous component. Now, in the new classification, adenoid ameloblastoma has been added as a new entity. There's about 40 to 50 cases that have been reported so far. Presents as a painless swelling. Again, a peak age of around 40 with a slight male predominance. And things that you need for diagnosis in ameloblastoma-like components. So you can see again those sort of cystic areas and the palisading, like here. You can get duct-like structures, areas very much like an adenomatoid odontogenic tumor, but you also get this sort of slightly whirling architecture and a cribriform architecture, so like almost back-to-back duct-like structures. It's also good to see other features such as dentinoid. So this pink material here looks like it's dentinoid. You can get clear cells and ghost cells as well. So it looks like an ameloblastoma, but it's got these features and hard tissue formation that you don't tend to associate with an ameloblastoma. And this paper actually highlights it quite nicely in terms of how adenoid ameloblastoma is different. It actually is borrowing features from these three different tumors, and it's almost like a hybrid of all of these. But one useful thing to know is that conventional ameloblastomas, a significant proportion of these will have the BRAF mutation, whereas adenoid ameloblastomas usually tend to lack that. Now, there's a malignant variant of ameloblastoma, which is extremely rare. Ameloblastic carcinoma is usually presenting in older patients, with the mandible being the most common site. If you look at the radiology of this is the mandible. You can see the superficial aspect here and the inferior aspect here. But in this area, you can see it's very unclear because the mandible seems to have disappeared, which tells you there's a soft tissue lesion which seems to have destroyed the mandible. So it's quite aggressive. And when you look at the histology, it shows that frank atypia or dysplasia you associate with other squamous type lesions. You'll see a lot of mitosis. Things like E67 can be helpful, but sometimes it can be quite challenging to diagnose these. And it's also important to make sure that you are ruling out a primary intraosseous carcinoma or a metastasis from somewhere else. Now, an orthokeratinized odontogenic cyst, this was re-added to the classification back in 2017. So previously, the belief was that the odontogenic keratous cyst has got a parakeratinized and an orthokeratinized variant. And now we know that the actual orthokeratinized variant is completely different and not a variant of the odontogenic keratosis. So you get this quite flat epithelial lining, and you get quite significant orthokeratin, almost like epidermis, with abundant squames within the lumen as well. You don't get the peripheral palisading, basal cell palisading, or other odontogenic keratosis-like features, which is quite important because it doesn't have the same recurrence potential as an odontogenic keratosis. Moving on to squamous odontogenic tumor. So again, very rare, and on radiology, you can almost think of it as a sort of bigger version of sclerosing odontogenic carcinoma. Very characteristically presents between the roots of the teeth and pushes them apart. Okay, almost always is a unilocular radiolucency, but when you look at the histology of it, it's very bland islands of squamous epithelium, and they shouldn't show any keratinization. Here's another example of a squamous odontogenic tumor. So you can see islands of squamous epithelium scattered throughout, very bland. There's some evidence of bone resorption, but there's no evidence of keratinization. So it's also useful to remember lesions which can show ghost cells. And one of the more common ones is calcifying odontogenic cyst. It used to be called a calcifying cystic odontogenic tumor, but now the terminology has been simplified. It's one of the most common ghost cell lesions, benign, age range of 10 to 30 years of age, and it's often presenting in the anterior maxilla. And sometimes you can also see it in association with an odontome. What you get is this quite well-defined radiolucency, okay? And occasionally it can have calcifications as well, but they don't tend to recur. So this is a case of a 60-year-old patient, quite extensive lesion here. On the CT scan, you can see the expansion of the mandible, and the 3D scan is also showing you the expansion and the extent of the lesion. And looking at the histology of it, you can see it's got a central cystic component, but then you got the cystic proliferations as well. And these will have an appearance just like an ameloblastoma. So you get the peripheral palisading and odontogenic epithelium. The other ghost cell lesion to be mindful of is a dentinogenic ghost cell tumor. This is a less common. This is less common than the other one, and has got quite a wide age range. Radiology is quite similar in terms of being radiolucent with some bits of calcification. It's got a slightly more recurrence potential than the previous cyst that we looked at. But you can see on histology, it's a lot more solid and a lot more cellular, so you don't tend to have that cystic appearance that you saw in the previous one. You can also get bone resorption. You can also get areas which look very much like amyloid. And then here are these areas which look very much like ghost cells. These sort of haloed out pink areas, which is just left like an outline of a cell. And these tend to be in close association with this odontogenic epithelium, and you can see there's some evidence of peripheral palisading there. So odontomes or odontomas are basically hematomas, but they are counted in odontogenic tumors. Younger patients can be seen in upper or lower jaw, and basically on radiology, it can look like just like an extra tooth, or it can look like lots of little teeth. So here you can see lots of different size specks of hard tissue, but in this one, there is an odontome which has got a much more organized structure and is almost looking like a tooth. And based on that, we call them either compound odontome or a complex odontome. So compound odontome has got a more organized structure, and complex has got a more haphazard structure. So here's sorry, this is meant to have a video, but it's not running for some reason. So here's an example of an odontome. You can see there's dental hard tissue here, okay? You can see that there is, so the actual enamel has been dissolved because this has been decalcified, but these areas here are areas of enamel matrix, so that unmineralized matrix will still be left behind. And you can also get more blue looking areas which are like cementum and sometimes even pulp. So this looks like quite a haphazard almost like a mess, if you like, of all the dental hard tissues that are present, but not in the right order. So another thing that's caused a lot of debate, or change that's caused a lot of debate, is that there was an entity, ameloblastic fibrodontome, and that was removed, and now it's considered part of the developing odontome spectrum. And there's a lot of discussion about that, because sometimes you can get quite large lesions, and they can cause resorption and damage to the adjacent structures, and there's still people who believe that these are actually two different ones, but right now the evidence is neither here nor there. So I think the WHO is sitting on the fence. So it's an example of a well-formed one. Here you can see this quite a well-defined lesion in the maxilla. It's got a corticated margin, okay? And looking at the histology of this, you will not see as much hard tissue in a developing odontome. You'll see a lot more soft tissue with a lot of odontogenic epithelium. Correlation with radiology again becomes important. Whereas ameloblastic fibrodontome, or what people advocate, some of these should be called, are quite extensive. And here's an example of one. It looks multilocular. It's caused a lot of damage and resorption of the mandible. It's almost nearing a pathological fracture. And that doesn't look like something that should just be called a hematoma, because this will almost certainly require a resection for removal. And this was one of our cases which actually was resected and reconstructed. But histologically, again, fairly similar. So you've got those dentine-like areas, and then you've got here ameloblast-like cells, the mesenchyme-like areas as well. Now, one of the more complicated areas is fibrosis lesions. I'll only cover the more common ones. So you've got the ossified fibromas, fibrous dysplasia, and cementoosseous dysplasia. The difficulty with these is that histologically they can look almost identical. So again, I'll go back to the point that you almost always need radiology and clinical information to make the diagnosis. Now, within ossified fibromas, we've got three different types. You've got cemento-ossified fibroma, which suggests that it's got an odontogenic origin. It's in the tooth-bearing areas of the jaw. And there are the two variants, juvenile trabecular ossifying fibroma and a juvenile cymomatoid ossifying fibroma. These can involve other bones, and they tend to be a bit more aggressive. If you look at them side by side, you can see that the juvenile trabecular and the cymomatoid bones are in younger patients, so children and adolescents, whereas cemento-ossifying fibroma is in slightly older patients. These will be in tooth-bearing areas of the jaw and largely in the mandible, whereas the trabecular ossifying fibroma can involve both mandible or maxilla, and the cymomatoid one can involve any bone in the maxillofacial skeleton, and it doesn't have to be just the tooth-bearing bones. So this is the most common type, cemento-ossifying fibroma. It's quite slow growing, and posterior mandible is the most common side. As I mentioned, it's tooth-bearing areas and tends to present as quite a well-defined lesion. It's got a corticated margin, so you can see this white border, which is telling you it's a slow-growing lesion. Inside, it's got a mixed appearance. You've got darker areas, the radiolucent areas, which tells you there's a soft tissue component, but also areas which are slightly more white or opaque, which tells you there might be areas with ossifications as well. And one thing that can be quite useful, but not always evident, is that the cemento-ossifying fibromas have got a very well-defined margin. So here is an example of the corticated margin of the lesion, and here's the actual lesion. So you can see they look very different. This is mature bone forming the margin of the lesion, and within the lesion you will have fibrous tissue replacing bone with variable sort of appearances. And the reason for that is it depends what stage the lesion is at. So sometimes you can have a lot of bone within these lesions. In other lesions, you can see a lot more soft tissue with only specks of bone. So it really depends at the stage of the lesion. In some lesions, you can also see quite prominent bone turnover. So the osteoblast can look quite plump and prominent and quite whirring almost. And fibrous dysplasia is slightly different because it's not a tumor. Like ossified fibroma needs to be resected just like ameloblastoma. So fibrous dysplasia is developmental or a reactive lesion. And about a quarter of these involve the head and neck. So it's very important to be mindful of these. Maxilla is much more commonly involved. And on radiology, this looks much less well-defined. So if you look here, you can barely tell that the lesion is there. It's not dark or radiolucent. It's almost blending in with the bone surrounding it, and it largely looks white. It almost looks like what people call a ground glass appearance or an orange peel appearance. It looks more white than dark gray. So you can get fibrous dysplasia in a single bone when it's called monostotic, but you can also get multiple bone involvement in the polystatic variant. And there are other forms. You can get it in association with McCune-Albright syndrome. And another useful thing is that a significant proportion of these show a GNAS mutation, which can be quite helpful in diagnosis. But on histology, you can see it almost just looks like normal bone sometimes. I mean, this does look like woven bone. There is more mature looking bone, but this is just blending in with that bone. You don't have that very striking border or cortical margin like you see in a cement-ossifying fibroma. But otherwise, histology can be pretty much identical. You go fibrous tissue. Some people used to describe that you can see more osteoblasts in a cement-ossifying fibroma, but you can also see osteoblasts in fibrous dysplasia. And I've seen ossified fibromas without osteoblasts as well. So the important things to remember are the ossifying fibroma is more well-defined, and it's got a clear margin, okay? And will often involve the mandible, whereas fibrous dysplasia will more commonly involve the maxilla, won't have a clear margin. And that is where the radiology becomes really, really useful and handy. Now, another thing which can look just like these lesions is cement-osseous dysplasia, which is again a spectrum of reactive lesions. You can get these multiple radiopacities, which are in the tooth-bearing areas of the jaws. And if you haven't seen anything like this, it can look quite worrying. So you've got three types: focal, periapical, and florid. And just looking at them side by side, focal is basically in just one area. You've got one focus of it. Periapical involves the periapical areas of the teeth, but can involve multiple teeth. Whereas florid actually can involve quite big portions of the jaws and sometimes even multiple quadrants. So those are the main differences between these in terms of the clinical distribution and the radiological appearance. Histologically, very much like a fibrous dysplasia or cement-ossifying fibroma, you've got this fibrous stroma with these scattered bits of bone, sometimes more well-formed, other times more smomatoid in appearance. In the florid variant, you tend to get more mature, dense bone and less stroma. Cementoblastomas can sometimes look like this, so it's important to be mindful of these. A benign odontogenic tumor. The most important thing about these is that they are attached to the root of the tooth, okay? Because the origin is in the cementum. And radiologically as well, you can usually see a lesion which has got this mixed appearance, more radiopaque, largely radiopaque, but also radiolucent areas, which is attached to the roots of the teeth. And looking at the histology, you can see it can look fairly similar. The one thing that's usually helpful is, of course, you get quite plump osteoblasts. You will see the dentine and cementum, which are in continuity with the hard tissue of the lesion, which is quite helpful. So I'm almost there actually. Looks like I'm going to finish early. So this is an entity which has just been added to the most recent classification, rhabdomyosarcoma with a TFCP2 rearrangement. These are quite aggressive, high-grade lesions with a poor prognosis. You can get multiple appearances. You can get epithelioid cells and spindle cells. And the difficult thing with this one is that it can show expression of cytokeratins like AE1, AE3, but also ALK. So here's an example case sent to me by a good friend of mine, which is from a 16-year-old Nigerian female. There's this big swelling which was involved in the gum and jaw, and you can see it's quite poorly defined. It's pushing out into the mouth and the oral cavity outside the bone, and it's also pushing all of these teeth outside of their sort of normal place as well, which tells you immediately it's something more aggressive. And looking at the histology as well, you've almost got these sheets of cells, which look quite small here, but in other areas look almost spindled. On higher power, you can see they're quite strikingly pleomorphic, almost epithelioid in places, multinucleated in other places, but there's also evidence of necrosis. And they can also show quite strong MyoD and myogenin expression, which is helpful. So it's something to be mindful of when you're looking at a high grade or a typical lesion within the jaws. Okay, to sum it up, there's a large number of odontogenic lesions, and they can show a range of appearances and sometimes these overlapping features. You don't tend to see overt atypia or dysplasia, but be mindful of that, and things like the rhabdomyosarcoma I showed you. Sometimes you can get primary intraosseous carcinomas. They actually show atypia, and that can be helpful. Think about your additional investigations in terms of the Congo reds, molecular testing, but again, be mindful that if you decalcify the block, that your molecular testing may or may not work. So it might be useful to save a little bit of soft tissue without decalcifying it for any potential molecular testing. And radiology is absolutely critical to diagnosis of these. Thank you very much. Happy to take any questions.
Thank you very much, Ali. Are there any questions from the audience? That was a really comprehensive talk. Any questions from the audience at all? So I've got a question. So obviously the radiological appearances are really critical. I probably hadn't realized just how critical they are in separating them out. Which do you think is the, in terms of people's practice, which conditions are most likely to be confused without consideration of the radiological findings?
Yeah, so I think the more common ones are, the most difficult one is, of course, an ameloblastoma, which can be confused for a cyst. So something like a dentagerous cyst, or an odontogenic keratocyst can look just like an ameloblastoma if it's unilocular. So that is one area where there is quite significant treatment implications, because you might just treat it incorrectly, particularly if it's got in cystic areas, but other areas it might look more solid, whereas the biopsy might just be from cystic area. So that's where it becomes very important. The other thing is fibroosseous lesions, I would say. So thinking about, again, cemento ossifying fibroma, which is a neoplasm and needs a resection, compared to fibrous dysplasia, where you might just wait and watch and doesn't need any treatment. Similarly, for cemento osseous dysplasia, you don't really need any treatment. You can just observe them, and they are reactive lesions. So I think it's quite important. And I have unfortunately seen those cases where a cemento ossifying fibroma might have been called fibrous dysplasia and no treatment offered. But then 4 or 5 years later, they're blown up into really big, significant things requiring massive resections. So it is quite challenging, but I think those are the two areas where it can be most helpful.
Yeah. And in terms of, is there a role for, I guess there's not a role for cytology in diagnosing these lesions?
Not really. A long time ago, people used to do some aspirates for odontogenic keratocysts and protein content, but that's no longer done, because biopsy is perhaps the most appropriate way of getting a diagnosis. So cytology is difficult because a lot of these can have these cystic areas, so you are never sure whether you're going to get enough of a sample. So yeah, it's not really done for these, or not really appropriate.
Yeah. And I guess it's also more excision specimens rather than any needle core biopsies in this area?
Yes,
because of the
absolutely.
nature of the tissue?
Yeah, so needle cores, again, not common. Usually an incisional biopsy followed by an excision, or if you're fairly sure, the surgeons are fairly sure this is a benign lesion, they might just enucleate or remove it in one go.
And just from the audience, I don't know if anyone is able to put their hand up as to whether they see odontogenic tumours in their practice or not. I mean, most people outside the UK are practicing more generally, so they have to deal with everything.
And I know for a fact that things like ameloblastoma is a lot more common in Africa. So
Okay.
you see a lot of cases from Nigeria and other places. It's significantly more common, and most patients tend to present at quite late stage, so it gets quite difficult to treat as well.
So I suppose in terms of distinguishing between reactive and neoplastic lesions, maybe, unfortunately in other countries it's easier to distinguish them just because the natural history has already progressed further. Yeah. Are there any other questions? And what are the most significant changes in the most recent classification, do you think, from previous one?
So the new one, actually, there's no radical changes. I think the categories have been slightly sort of modified, but there's only one actual new entity. So I wouldn't say this one has been groundbreaking in that sense, which is good. The last one had a fair few things like the sclerosing odontogenic carcinoma and the clear cell odontogenic carcinomas, but we are understanding these more and more. So I'm sure more will be added to this. But the most recent classification actually is pretty much an update to the previous one with just one or two things that have been added. In particular, the rhabdomyosarcoma that I mentioned. I can see a hand up.
Oh yeah, someone. So someone put their hand
Thank you,
up.
Prof. Thank
Yeah,
you.
go ahead. Go ahead.
Yes, because we are from varied backgrounds, and in our setting, occasionally we see involvement in the oral cavity, especially the soft part of lymphoid neoplasms. What sort of lymphoid, or do you see at all, especially bucket and plasmablastic lymphoma? When you see them in the oral cavity and the jaw, do you still classify them as WHO classifies? Are they included among the head and neck in the same way? Thank you.
Richard, you can probably answer the question better than me.
So just remind me the question again, please.
The question was about lymphoid lesions of the head and neck, and would you classify them based on the heme?
I classify them based on the heme.
Yeah.
Based on the heme. Yeah. So the heme, obviously the heme tumors, they occur everywhere, don't they? So, location is less important to us. Obviously, location is important, but as my hematology colleague said to me, it's in the blood. It goes everywhere. So, yeah, I would classify it. And, diffuse large B-cell lymphoma is common in the head and neck, marginal zone lymphoma, and then any of the other small low-grade lymphomas. So mantle cell in the head and neck as well. Less so follicular, probably. And then all the MALT lymphomas, the various MALT lymphomas, salivary gland tumors in particular, quite common in Wilder's ring and around that area. Yeah.
Seen a few plasmablastic ones recently as well.
Yeah. And I guess in countries with a higher HIV incidence, you're going to get more plasmablastics and EBV positive lymphomas. Yeah. Hodgkin's as well. Less so in the head and neck, maybe. Maybe back of the oropharynx. Yeah.
Thank you.
Any other questions? If there are not, I'll